Please welcome to the stage Foreign Policy's publisher and CEO, Andrew Sollinger.
Everyone. Good morning, everyone. Thank you. That was very good. Welcome to Foreign Policy's Global Health Summit at the World Health Assembly, the curtain raiser of this year's World Health Assembly, and we really appreciate you being here. I see more people walking into the room. I have to say this as a son of a teacher. Plenty of seats in the front up here. Please come forward. You're all in the health industry. Many of you medical professionals, you're used to sitting in the front row and raising your hand frequently. So please come forward. There's tons of room and space. I just wanted to set the stage a little bit for the discussion that we're having on why we're here. It's a critical moment in global health, as you know. We're looking way past COVID-19. On the previous discussions that we've had here at the World Health Assembly, it's been very focused on lessons from COVID-19, but there's so many more factors at play right now. Obviously, we've got the climate impacts of changing climate and environment on healthcare. We've now got global conflicts around the world that are exacerbating the situation. And then continued rising inequality that we have to combat as well. So it's a very trying time for us, but now you add into the mix a sea change in government policies, aid and financing for multilateral institutions, including on healthcare. And that is really very daunting and a precarious position for us to be in. But it also creates an opportunity. It's an opportunity for us to galvanize all the thinking and talking we've been doing over the course of the past several years and put these thoughts into action. And I'm very pleased that you're all here with us today because you are the people who lead these policy initiatives and can impact that change. You can make it visceral and tangible in your communities and in the areas that you specialize in, and we're looking forward for you to doing that. We're bringing together a lot of interesting speakers for you today, and from lots of different sectors, international organizations, government, the private sector, civil society, and we're going to ask some tough questions. How do we move from crisis response to long-term resilience? We're going to talk about rethinking global health financing, and we're going to talk about creating what is a truly resilient and inclusive system. So let's challenge some assumptions, spotlight solutions, and as I said, center the communities that we serve. Thank you for being with us here in person, and also thank you for being with us on live stream. We're live streaming this right now to a global audience. And I want to thank our partners, without whom we would not be here today, and we could not make this possible. That includes Bayer, the McKinsey Health Institute, Nura Health, thank you, Seed, Vestergaard, Vital Strategies, and the World Health Summit we're partnering with as well. There's lots of material on your tables in front of you. You will see principally a green card, I believe it is, that has a QR code on it with a link to the agenda, biographies of everyone that is speaking here today, so you can use that to inform you on the event. You can flip the card over, and there's another QR code to subscribe to Foreign Policy. There's a magazine, of course, we do a quarterly magazine, but we're really a strong digital organization. And if you subscribe to FP, not only will you learn all about the incredible coverage that we have in this space in health and climate, but also the work that we do on trade and technology regulation and national security, and you'll be better informed globally, plus you'll help support FP and keep us vibrant and moving forward. There's also a variety of cards with QR codes to research that our excellent team at FP Analytics has produced with many of the partners that I just recited. We have some focuses on NCD finance in developing countries, combating malaria, family planning, menopause, not often talked about, taboo subject, fascinating, and climate and health. So please do explore those projects. It's really interesting and hard-hitting research. You just had kind of a late breakfast. We're also going to serve you a late lunch just after 2 o'clock when we finish. So please stick around, and I hope you're fortified. And we'll get going. I see some people in the back. Please do move forward. There's plenty of seats in the front here, lots of room. Let's begin the program. Dr. Jean Kaseya, please take a seat over here. We were going to
Please
play.
welcome His Excellency Dr. Jean Kaseya, the Director General of the Africa Centers for Disease Control and Prevention, to discuss the state of global health with Foreign Policy's Andrew Solinger.
Dr. Jean Kaseya, you're so important. We introduced you twice at the World Health Assembly here, Global Health Forum at the World Health Assembly. Thank you for joining us. We know you have a super busy schedule. We were just talking about this, and we want to kind of pull into what's working with the Africa CDC and some of the ways that you're approaching the conundrum and opportunity that I just described. So to kick off, you have said in past and emphasized that African solutions to African health challenges are what's needed. What does real health sovereignty look like right now for the continent?
When I think about sovereignty, I think about innovation. But before saying that, let me tell you that you wanted to create trouble in my life. Why I say that, you know, I have the president of Angola speaking today as a special guest to WHO. And the president of Angola is leading the African Union. I'm head of organ of African Union. You know what I did? I went to apologize. I said, President, I'm invited to FP event. He said, oh, this is important. Please go. You'll miss, but go.
We're honored. Thank you.
Because FP is more completed the way we are approaching our issues in Africa. And to come back to what you are saying, when we talk about innovation, we are talking not only about the programmatic innovation, it means digital health, telemedicine, AI. We are also talking about innovation on how we are taking over. We are taking back our sovereignty in terms of health financing. Please go to the Africa CDC website, look for this book. You know, the trend today is all African leaders and head of state, they want to take a photo with this book. It's like when the Me Too movement started. Everyone wanted to take a photo with Me Too. Now they are taking photo. Even Tedros took a photo with this book. This book is a blessing that we have in Africa in terms of rethinking our health financing when we are experiencing the health cut. We are impacted. But we are also talking about another innovation that is how to reform our policies. We are talking about local manufacturing. Are we buying our own product? What is the barrier? And we are also talking about innovation in terms of how are we reshifting the global health architecture. Today, for the very first time, Africa is leading response to major outbreaks. Take Mpox. Africa CDC declared the public health emergency. Africa CDC decided to put in place the incident management support team. With my brother Tedros, we say, let us call it that. We have 28 partners coming together to respond to Mpox. And I was briefing my leaders in February. For your information, for the very first time, they gave an award to Africa CDC to end organ. I think we are proud of that. And we are looking for solutions for African problems.
First of all, thank you for joining us. The name of the book, the title is Africa's
Health Financing in a New Era.
In a New Era, a concept paper from April, from last month. So please do have a look at that on Africa CDC site. Let's. I want to unpack a little bit of what you just mentioned on financing, but I want to first start with Mpox. So when you declared Mpox a health emergency in August of 2024, there were there were cases in 6 countries, and as of last month, 21. Is that accurate?
Now 24.
Now 24. How is Africa going to respond to outbreaks like this without that financing support from organizations and governments like the United States?
I said to my communities and to my countries, I feel proud to be African leader. You know, for all outbreaks that we had in the past, all of them, no one in Africa could give you data. No one in Africa can give you how much we're receiving and where money was going. For Mpox, I'm able to tell you how much we received, where money is going, what is the impact of this money. You can imagine, let me give you an example. When we went to our member state 1 week ago, I told them, with money that we received and internally in Africa and from partners, this is how we use that. 3 days ago, they gave us $28 million additional, coming from our member state. I have countries like Angola, Morocco, and others pledging funds to Africa CDC because they see that we are not only transparent, but we are making impact. For us to respond to this kind of outbreaks, I was meeting the president of Ghana 3 days ago. He was telling me, Sierra Leone is burning. How can we prevent to have this outbreak in my country? I flew to Geneva. Then when I landed, I got a message from him, Ghana is infected. What it means? It means we need first to think about local manufacturing of vaccines. Let me tell you, every single day, when I say every single day, it means last year we had 213 outbreaks. This year, it will be even worse. It means it's almost one outbreak per day. Every single day, I have to think, where do I think I can find vaccines, medicines, diagnostics? Without this strong local manufacturing agenda, we will not move. Without global cooperation and collaboration, we will not move. We still have countries that pledged money for mpox. We didn't receive so far. We are calling them to continue to provide. And also, we need data sharing agreement. We need to know when something starts somewhere, all countries are informed on timely manner. I think this is what we are doing to manage this kind of outbreak. We did it recently in Tanzania. You saw my action for Marburg in Rwanda. I think today, Africa CDC is on front line, working with all partners to deal with all outbreaks.
Very interesting. So you're really talking about how this crisis in financing and funding and multilateralism is creating opportunity, as we were discussing earlier, as I was mentioning earlier, for countries and the continent to galvanize that support for each other and focus on that. And also when you talk about that logistical challenge and making sure that you have that localized resource and ability to produce, that also creates economic opportunity. It's a virtuous circle as well. So that's really helpful. I'd love to understand a little bit about how that relates to other regions and how Africa CDC works with other regions. How important are regional partnerships in other areas of the world to the work that you're doing on the continent now?
It's so amazing. I think all of you saw this article in The Lancet. My brother Jarbas was leading PAO. We signed the MOU. Now PAO and Africa CDC, we are working together. I was with, I don't know if he's still minister in Singapore, Minister Ong. I was with my friend, I think he will be here after me, Budi, from Indonesia. Now, ASEAN, they want to create ASEAN CDC following the model of Africa CDC. Gulf CDC, they want to follow the model of Africa CDC. Why the model of Africa CDC? We need a strong political, strategic, and technical organization to lead the agenda and to talk with other continents. This is what we are doing. I think this article in The Lancet, I saw some people saying, why we cannot create the Latin America CDC. It's public. Now, the way Africa CDC is working is really to be connected with all regions and to work close with WHO at global level to facilitate the discussion. The last one, for the very first time, the DG Africa CDC is invited to the WHO. In the past, we were invited under the African Union. It's showing to you that today, Africa CDC is very well respected.
That's wonderful. And we're going to have Jarbas Barbosa here a little bit later, so we'll talk to him about that partnership as well. Africa CDC launched its new public health order, and you have a lot of interesting components in there on workforce, manufacturing, you just mentioned, surveillance. What's most important? How do you prioritize those?
The most important for me is what is helping me to save lives of my people. I have so many people dying every day, first because we don't have availability of medicines, diagnostics, vaccines. And this is my first priority. The second priority, for us to have that, we need to rethink our health systems. You know, the problem is not just the headcount. The problem is the governance. If we have to stop today with fraud, corruption, misuse of funds, even with the current funding that we have in Africa, we can make an impact of more than 46%. It means, and this is the study that we conducted, it's available in our website. It means today, my priority is not to go back to request for ODA. My priority is to reform the health system in Africa. Do you know that only 16 countries out of 55 have National Health Development Plan costed in Africa? If you don't have a plan, how do you want to request domestic funding? How do you want to talk with partners? This is why I'm saying, even to some partners who are coming to tell us they are filling gaps in other countries, I say, you are not helping us. Because we are continuing with the old model where people, they're not doing effort. Let us stop that. Let us move with another mentality. Let us push our countries. I'm an African, I'm a leader. I'm saying that with responsibility. You don't have a plan, you don't have a costed plan, you will not get money from outside. I did it even in my own country, DRC. They came to me, they said, I have 45 million plan for Mpox. I said, if you don't give money, we'll not get money from outside. They gave 10 million, and we got around 200 million for them. I think this is the model that we are following.
I like. Can you expand on that? We only have a few minutes left, briefly, on what role, where we've just spoken about how the funding and financing and different institutions that are supporting that have changed. How can the private sector support what you're doing?
If you read this book, you will see we have 3 pillars. The first one, more domestic resources. The second one, more innovative resources with what we call the Lusaka agenda, alignment. And the third one is the blended finance. It means investment from private sector. We need African and external private sector to invest. It's a win-win. Now, in the world, we are talking about transactional approach. In Africa, we want people to know that they can make money and that money can also save our life. I think private sector is playing a key role, and we are putting in place the conducive environment for that.
We talk about that a lot at FP, and that's the reason that we focus on this sector so intently. Human ROI, human return on investment. It's about humanity, but there's also economic benefit in there. We only have about a minute and a half left, so just as a final kind of question, you're meeting with lots of people. We were trying to tally up how many meetings you have here this week. Let's just say for a moment your final meeting at the end of the week is with the leaders of the G7. What message would you want to convey to them? What would you like to say?
2 key messages. And I'm meeting Peter Sand, Sanya, I met Tedros. Yesterday I was with United. I was saying, my first message is, let us support replenishment of these organizations. Because 70–80% of this money is for my continent. This is the first message. The second one I'm telling them is, let you support us to rethink our health system in Africa. We don't want you to come to fill the gap. There is no gap to fill. There is a rethinking to do. Rethinking, it means help us to take the ownership of our program with your support, because we still need partnership. Please come to be aligned with us, and we'll make this huge impact, and that will be a win-win for everyone.
Wonderful. I think it's fantastic and great thoughts for you to share with us to kick off our program at the Global Health Forum here at WHA. We're so appreciative that you made the time for us. Dr. Jean Kaseya, please join me in thanking him.
Thank you so much.
Right this way.
Thank you so much.
Please.
Next, please welcome Dr. Ade Jubeida, head of the Indonesian Wives Association, Dr. Shahed Alam, the co-CEO and co-founder of Nora Health, and Dr. Pascal Alote, the director of the Sexual and Reproductive Health Department at the World Health Organization, for a conversation with Foreign Policy's Executive Vice President of Analytics and Events, Alison Carlson, on the essential role of caregiving.
Good morning, everyone. Thank you so much for joining us today on a very packed week. I'm really excited to kick it off with all of you here in the room. It's an absolutely packed room. And following Jean Kaseya, thank you so much for joining us. You know, what we hope to achieve here today is really elevating both experience, expertise, and lived experience, and finding ways to translate that lived experience and expertise into policy and action. And moving from, a few of the words that Andrew mentioned at the outset is we really want to challenge conventional wisdom and talk about those things that are underappreciated, unrecognized, and what more needs to be done to drive impact and outcomes. And so I'm thrilled to be able to moderate this conversation and start the program today talking about an issue that goes far too unrecognized and unappreciated, which is caregiving. It's something that isn't talked about often enough, but that all of us can absolutely relate to in our lives, in our work. And I think there's a lack of understanding about the degree to which caregiving that is often informal and often unpaid really contributes to healthcare outcomes and mitigates costs on the system. But we need to formalize ways to integrate caregiving into national healthcare strategies. And so that's what we're here to do today. So thank you to Nora Health for joining us. And Dr. Alam, I'd like to kick it off with you. You've worked in countries around the world from Bangladesh, India, and Nepal. And when we're trying to translate experience into action, I'm wondering if you could start us off with sharing a little bit more about the experience you've had and the programs you've had working on the ground and how you've seen caregiving really translate into impact in healthcare delivery.
Sure, thank you, Allison, for that question and for laying the context. We started on this journey recognizing that caregivers are really an untapped resource. In households around the world, this concept that we care for the ones we love happens universally. It happens whether you're in a rural area, urban area, across contexts. But at the same time, we also see that this goes unsupported by the systems and the structures around them, especially health systems. And we see this as a missed opportunity. Of course, health systems are constrained themselves. There's nearly going to be a shortage of nearly 18 million healthcare workers by 2030. And there's many other stats, of course, that prove the point that systems are constrained and they're doing their best. And oftentimes we see, when we think about health, we think about health happening in hospitals or clinics. But really, the vast majority of health and care happens at homes. More than 80% of long-term care, for instance, happens by informal caregivers or family caregivers, whether it's a family member themselves or a loved one, maybe a neighbor or someone else who's loved by a patient. But oftentimes, again, the systems around them don't support them. So what we try to do is to partner with health systems, typically it's the government, and really integrate how caregivers can be supported within the process of care delivery. So it's not something that sits outside the system, not an extra nice to have, but really just integrated into how systems care. We do this in a few simple ways. We work, of course, very closely with our partners in identifying how does this get integrated into these care delivery systems, not just for one or two types of patients, but across the life cycle, from antenatal care, postnatal care, to NCDs and serious illnesses. And we do this in a simple way, have families be trained in healthcare facilities, and then have them be followed up at home over their phones. And one of the key elements that we try not to miss is recognizing that most caregiving happens by women and girls in the countries that we work in. More than 4 times as much caregiving hours or effort is spent by women than men. And so what we try to do in our program at every touch point is to bring men in, is to have them be trained. We invite them into the trainings that we do. We recognize that men oftentimes have access to the phones, that we send the messages over, so we tailor messages and tailor content to them so that they acknowledge and understand their role in care. And there's other ways we do this too, but I'll share those for now.
Thank you.
And I'll pause there. Yeah.
Perfect. We'll dive into some of the mechanics and specific examples in a moment, but thank you for helping set the stage. And you mentioned the role of women, and Dr. Lotte, I'd like to turn to you. You have a tremendous breadth of experience in sexual reproductive health and rights, and also with your years-long career, really focused on gender and human rights in global health policy. And so when you think about caregiving, how are you seeing this manifest as it relates to women and families? And what are some of the aspects of caregiving that really are under-recognized, not well understood, and that we really need to focus on as part of this conversation?
Great. Thank you very much for that. Is that working?
Yes.
Yes, thank you for that, and thank you everyone for being here and for your interest in this particular topic. The global unpaid care economy, and this is according to an ILO review, is valued at over $11 trillion annually, which is nearly 9% of global GDP. But caregivers aren't being paid, but we do know that it is part of, as human beings, as societies, we look after each other. So there's nothing kind of really magical about this particular topic. However, I think in the moving from what happens as part of our societies to trying to formalize this as part of a health system, we really do need to be very, very clear and very careful about introducing extra gendered, very much gendered issues within this. We have to resist framing this solely as a cost-saving strategy. It does need to be paired with investment in professional care and caregiver support, so that we risk institutionalizing this notion of an unpaid, feminized labor. Caregivers are often women and face long-term emotional and financial costs. This isn't just about training, it's also about ensuring caregiving is not just used as a way of plugging holes in an underfunded system. If I can very quickly go to nursing, a nurse midwife by background. 30 plus years ago, when we started talking about bringing in traditional birth attendants and traditional healers, looking at alternative caregiving forces as part of the workforce, it was always thought of as a stopgap measure. We're only doing this until we have enough doctors or enough health systems and so on. If we are going to bring this properly into a system, we have to make sure that we anticipate what the issues are. So from my perspective within the context of WHO, we really do need to think carefully about what the evidence is to be able to back this and to be able to do it properly so that we are not introducing inequities in a system that is already inequitable, that we're not overplaying and overemphasizing the feminization of the workforce.
I'd love to dive into how to integrate that evidence into policymaking and draw on your experience a little bit more in just a moment. But first, I'm going to pick off what you said related to your experience as a nurse and a midwife. And Dr. Jubadah, I'm going to turn to you. You're the president of the Indonesian Midwives Association. And I'm wondering if you could provide a bit of perspective from Indonesia and the experience that you're having and the work that you're doing and the association as it relates to caregiving and how you're formalizing that within the context of national care.
Okay, thank you. Thank you, everyone. I am Ade. I am President Indonesian Midwife Association. I'm sorry, I'm Indonesian. Baik. Saya selaku Ketua Umum Pengurus Besar Ikatan Bidan Indonesia menyikapi hal ini, bagaimana peran keluarga di dalam pembangunan kesehatan, di mana pemerintah Indonesia ini sudah membuat sebuah program dalam rangka untuk pendekatan keluarga, pendampingan keluarga, yaitu dengan pendampingan keluarga, di mana pada saat tim pendamping keluarga ini, bidan juga tenaga medis dan tenaga kesehatan berperan bukan hanya sebagai care provider, memberi layanan mulai dari masa remaja, masa kehamilan, persalinan, nifas, bayi baru lahir, balita sampai anak prasekolah. Tapi yang tak kalah pentingnya adalah di mana peran tim pendamping keluarga sebagai pendamping keluarga juga samping itu juga sebagai community leader, penggerak peran serta masyarakat. Nah, yang paling utama kita juga di Indonesia sudah ada regulasi yaitu tentang primary health care dengan nomor 43 tahun 2019 bagaimana promotif dan preventif di layanan primer dan juga bagaimana integrasi layanan primer ini juga merupakan bagian dalam rangka untuk pemberdayaan masyarakat yang di dalamnya ada posyandu, puskesmas atau juga bagaimana juga kita memberikan pengasuhan kepada keluarga dengan memberdayakan anggota keluarga. Contoh ketika mereka keluar dari rumah sakit di mana dengan menggunakan media sosial ataukah grup WhatsApp dan lain sebagainya di mana seorang tenaga medis maupun tenaga kesehatan ini melakukan edukasi kepada keluarga terkait dengan masalah-masalah kesehatan yang ada ketika mereka sudah keluar dari rumah sakit. Okay.
Thank you, Dr. Jubaida. And please, if you could please translate that for our audience.
I can share a few points from Ibu Ade. First one is actually in Indonesia health program. It has been existing a program which is empower the family caregiver. For our experience in midwife association, midwife has two roles. Number one is as a care providers. But secondly is to provide education to family caregiver. And second one is in terms of policy, Indonesia has a quite comprehensive regulation in preventive and promotion aspect, and it is already started to be integrated with the primary health care, where the family empowerment aspect is very highlighted, very focused in the policy. And also the bidan, the midwives, they are very active also in educating the family by using social media, for example, in their program.
Thank you for that. And I appreciate you elevating your experience from Indonesia, and I think it's emblematic of some of the challenges and also opportunities that others can learn from and integrate into national policy. I'd like to talk a little bit more about that formalization, and Dr. Olote, I'd like to turn back to you. You know, in the context of your work across multilateral organizations, how are you helping connect those dots from what is happening on the ground and caregiving that's happening within families to integrating that into multilateral frameworks and also national policies? How can this be more effectively prioritized?
I think, again, I will go back to the critical use of evidence in this, and I'll go from the ground, actually, person through to the policy level. So a very specific example with family caregivers, there was when I worked in Malaysia, not Indonesia, a particular case of a caregiver had come in with a family member, and the treatment, there was a really interesting discussion about, in terms of the person's treatment, whether the treatment was specifically for the person or for the carer. So it was an issue with dementia, and the treatment could have supported the patient to be as autonomous as possible. But that autonomy meant that for the caregiver, they needed to be a bit more vigilant. So from the caregiver's perspective, they would have preferred a treatment that would make the person calmer. So it is once we start talking about specifically what this means and how it is we're going to promote this within a system, we have to understand exactly what that means, so that we're not formalizing something that creates inequity within the relationship. And this is why I keep going back to that. So yes, it is, caregiving happens, but how do we make sure that if we want to formalize this into a policy framework, that we understand what it is we are moving with, that we're moving to formalize. There are real potentials and challenges here if we don't really understand what the equity issues are that we might be introducing. We need to make sure that we're not supporting governments to abrogate their responsibility to ensuring the best care for people as well. So it's absolutely critical. I'm not there, I'm totally supportive, but we need the real evidence base to make sure that the policies that then get introduced are not creating harms that we're not anticipating.
Thank you for that. And picking up on that point, Dr. Alam, in the work that you're doing at Nora Health around the world, how are you working to collect that evidence base and then partner to ensure that the experience, the evidence, and the issues pertaining to equity are in fact translating into those partnerships, into policy, into programs that get funded? How are you connecting those dots?
Thank you so much. And Dr. Lote brings up some really important points here. To build on that, how we look at this evidence initially is to see how does supporting a caregiver, how does it actually support the patient's health outcomes? That is, of course, kind of fundamental to why the caregiver is also, performing in his or her role. And so what we try to measure is what are the patient outcomes that are actually being affected by this. And we've seen across a whole host of different patient populations, for instance, a reduction in post-surgical complications, things like wound infections, respiratory infections. By supporting a caregiver in that critical period to be able to recognize a warning sign, to be able to get them to get care at the right time, can actually bring down those complications. We've also seen a reduction in things like readmission. So people being able to catch, again, things early on, being able to go to a primary care doctor for care, perhaps get antibiotics and not needing to go to a hospital, which would then cause them to take days or weeks off of their life to be there again with their loved one, causing the caregiver additional burden. And we've even seen a reduction in things like newborn mortality, which of course is devastating and far too high in the regions we work in. So those, of course, what I just mentioned are they're evidence that supporting caregivers is a cost-effective way to improve the patient's outcomes. But I don't think it gets to exactly all of the important points that Dr. Lote mentioned. What we try to do more and more now is measure the burden of caregiving and how much are we able to actually move the needle in bringing men into caregiving. That's something that we are trying to hold ourselves accountable to while it's early on and get that embedded within the government health system. So kind of that redistribution of just what it means to care. And there's, of course, other measures of equity. What we have anecdotally seen is that getting caregivers the support to care for the patient benefits themselves and their own health as well. For instance, we've had anecdotes several times. Of course, some of this stuff runs in the family. So things like diabetes, hypertension. When a caregiver gets trained in a hospital setting, we've seen numerous times how they are more aware of getting their own health checkups done. And again, numerous times that people get diagnosed with diabetes and then eventually on a treatment. And then we do also measure, softer items like anxiety, caregiver support measures, and see that those things reduce as well. But I do agree that there's a lot more that needs to be done, both in terms of research and evidence, focused on the caregiver themselves and not just the patient, before we and as we integrate this into broader healthcare policy.
Great. And then, Dr. Jubaid, I'd like to pick up with you then. In your experience and in Indonesia specifically, what are some of the lessons learned regarding how to systemically integrate caregiving into a national policy based on experience and based on the evidence? Again, I think there's a lot to learn from your example there.
Bagaimana upaya-upaya yang dilakukan, kebijakan-kebijakan yang sudah ada ini mungkin diintegrasikan dengan kebijakan-kebijakan nasional. Yang paling utama adalah dengan adanya saat ini program yang sudah dijalankan dengan adanya 6 pilar transformasi kesehatan, baik itu melalui transformasi SDM, transformasi digital, dan yang tak kalah pentingnya adalah untuk di pendampingan keluarga ini bagaimana penguatan di integrasi layanan primer ini merupakan salah satu bagian yang penting yang perlu lebih ditingkatkan. Dan tak kalah pentingnya mungkin sedikit saya izin menyampaikan bahwa dari saya izin menyampaikan praktek baik yang sudah dilakukan di Indonesia, bahwa Indonesia memiliki 17.000 pulau, kemudian Indonesia juga memiliki 85.000 desa yang tersebar di seluruh Indonesia dan 514 kabupaten kota. Ini merupakan salah satu bagaimana teman-teman kami Bidan Indonesia berada di 85.000 desa, itu bidan ada di 85.000 desa, dan dari 550.000 bidan Indonesia mereka ada di 85.000 desa, sehingga dengan demikian 70% bidannya Indonesia ini ada di layanan primer dalam rangka untuk melakukan baik deteksi dini, screening, dan juga bagaimana upaya-upaya pendampingan calon ibu, mulai dari calon pengantin kita lakukan pendampingan selama 3 bulan. Kemudian dari itu bagaimana pemeriksaan antenatal care terpadu terintegrasi antar profesi, interprofesi, ini juga dilakukan kolaborasi, dan kemudian juga bagaimana pertolongan persalinan sampai kepada pemberian KB pasca salin, ini juga dalam rangka untuk menurunkan kejadian angka kematian ibu, angka kematian bayi, dan yang tak kalah pentingnya bayi baru lahir, balita sampai anak prasekolah, ini juga merupakan layanan yang terus dilakukan. Dan bagaimana program-program ini terus dikembangkan, tentu perlu diintegrasikan dengan berbagai program lain, dan yang tak kalah pentingnya adalah bagaimana kolaborasi. Dan satu hal, Indonesia dengan berbagai macam karakteristik dan juga infrastruktur yang sangat bervariasi, ini juga penting sekali untuk mendapatkan perhatian terkait dengan yang perlu ditingkatkan adalah bagaimana terkait dengan tenaga-tenaga medis maupun tenaga kesehatannya. Mungkin itu. Ya.
It's quite long and so many points. I will try to make sure that everything is covered. Yeah, first one, I think Ibu Ade mentioned about that the existing policies have been quite promising, and it's already translated from the 6 pillar of health transformation, and it's already also directed to the integrated of primary health care, and this one is implemented in the whole Indonesia. And Ibu Ade mentioned that while the policy are quite good, programming aspect is another one to be given attention to, because any policy need to be materialized, concretized, and it is through a program. Ibu Ade mentioned the good practices that is done, a program that is done by Midwife Association. She mentioned that Indonesia is a very large country. We have 514 districts, 17,000 islands, 85,000 villages. And the bidan midwives, they are existing in 85,000 villages. So in Indonesia, we have 550,000 midwives, and they are separated or distributed to the 85,000. And 75% of midwives are existing in the primary health care in the village. So this is a very good practice according to Ibu Ade. And as she mentioned earlier, they do both care providers in a whole life cycle, from pregnancy to the elderly. And it's also the second role is to provide education, a companion to the family in the village level. They also do the screening, the preventive and promotion aspect very much. And even they continue to after delivery, for example, they also serve in the family planning aspect. Children also become their target. And this is a good program in Bidan, midwives. Her suggestion is to make it better is how to integrate this program with other programs from other institution or department. And this is kind of a big main suggestion for integration in Indonesia.
Thank you for showcasing those examples. I think there's a lot you touched on there, including the distribution of care into very remote areas. And I think that's one of the challenges we'll be talking about a lot today, is how to make sure to increase access, but particularly in rural areas as well, and in the case of Indonesia, with so many islands, and being able to provide that care and integrate the care in terms of primary care as well is really important. And when we think about systemic change and greater integration, I think those are lessons we can all learn. You know, Dr. Olote, you mentioned at the outset the need for greater investment, and I think today and this week we're going to hear a lot about need for investment, need for financing. And in the case of caregiving, we know that so much of it goes unpaid. And so many countries have a limited fiscal space to invest in healthcare. And so when we think about the need and trying to formalize caregiving and integrate caregiving into a health system, from your perspective, what are the kinds of investments, and Dr. Lam, I'm going to follow up with you, what are the kinds of investments, and very specifically, the kind of mechanisms that can provide that support, both for integration and financial support for caregivers? Dr. Olote, please.
Okay.
I know that's a big question, but if you could try to tackle it, I'd appreciate it.
Financing caregiver support has to move beyond at the moment. We've got, thanks to the work of Nora Health, there are more and more examples of how we're beginning to work to finalize, to kind of standardize this work. There's also, from my department in particular, quite a bit that we're doing on self-care interventions as well. So just recognizing the care continuum from the person to the carer and so on. But obviously, if it's going to be tied to universal health coverage, and we are going to make sure that it's formalized within it, it does need to be properly financed. In countries like, I think, Sweden and Japan, we're very well backed by the state, which includes paid caregiver leave, pension contributions, and so on. Obviously, for a lot of the lower middle-income countries, we're not quite there yet. But at least if we begin thinking about it now through social protection and so on, we should be able to think about how we can properly finance caregiver allowances, tax credits, and so on. I do think that the public-private partnerships have a role. The private sector can be useful, although we do have to make sure that it's regulated so that it doesn't become commodified. But partnerships can be a really important part of it.
Thank you for that. And Dr. Lam, if you'd like to pick up on that, what are some of the mechanisms to formalize and institutionalize caregiving within the context of broader policies, and specifically as it relates to financing?
Sure. I think at a basic level, for instance, the work that we do at NORA, which is to support basic health skills training of family caregivers within the health system context, those budgets actually already exist. Oftentimes they actually go underspent. So things like IEC or training budgets, capacity building budgets, they can be reoriented to be more family-centered rather than just health system-centered. And I think that's like a shorter-term reorientation that can happen now in most contexts, and how we typically finance the programs that we implement in partnership with governments. But I think, again, a lot of great points brought up in terms of what more can be done in the future. I think two additional ones to highlight is not just the formal workforce, but informal workforce, and keeping kind of caregiver protections for them. They may not be able to get the same type of protection from an employer, but somehow creating a mechanism where they also can take time off or be there with their loved ones during times of need. And then again, kind of reimbursing for specific caregiving tasks. There are examples like the ones that Dr. Olote mentioned around the world, and they can be contextualized. I think with forward thinking within lower health system resource contexts, again, within a UHC context, that becomes more and more possible. So the very basic, again, can be born, we think, in the short term through these mechanisms, but there's a lot more that we can do in research for the future.
So we just have a few minutes left, so this will be a speed round, and ask you to keep the comments brief, but also really pointed and concrete. So this is the World Health Assembly. There's a real opportunity here for action, And so if there's one call to action that you could each have from this week, from those in the room, from those who are in positions of decision-making authority, what would that be? Dr. Jubadea, I'm going to turn to you first.
Yeah.
And we only have about a minute left, so if we could keep it brief.
Oke. Ya, yang paling utama mungkin lebih kepada bagaimana dukungan pemerintah, terutama bukan hanya di tingkat pusat. Mungkin tingkat pusat kita sudah sangat bagus sekali dengan berbagai macam kebijakan-kebijakan, tapi bagaimana implementasinya ketika kita mau melaksanakan peningkatan kualitas layanan ini dengan pemerintah daerah baik dan juga pemerintah di bawahnya ya, baik kabupaten kota, provinsi dan juga yang lainnya. Dan yang tak kalah pentingnya dukungan pemerintah di daerah itu juga bagaimana kami juga memerlukan adanya kolaborasi bukan hanya dengan tenaga medis tapi juga dengan tenaga kesehatan lainnya dan diimbangi juga peningkatan kualitas ini, peningkatan kompetensi dari masing-masing tenaga medis dan tenaga kesehatan. Thank you. Yeah.
So Ibu Ade has two recommendation. While the national government support for caregiving is already in a satisfactory level, she expects more from the government, lower government level like provincial government and district government and sub-district government. So if that is also in the same level like national, that would be better for health workers to implement program. Secondly, she highlighted that how we can collaborate more with the other type of health workers, not only midwives, because that collaborations now is need to be prioritized based on the target of the government. And also the improvement of the health workers' competency is also needed to have a standard quality, something like that.
Thank you for that, Dr. Lam. And then Dr. Lote, we'll close out with you.
Sure. I think I'll start with the fact that we're all caregivers. This is something that us as humans, every one of us will experience, caring for the someone that we love. And so just drawing from that experience, everyone in the room and online, bringing that into the work that we do and lead and putting caregivers at least somewhere in that work.
Thank you for that. And Dr. Lote?
We need to make sure that that caregiving is gender transformative, recognizes caregiving as work, and challenge assumptions about who provides care, ensuring that there's male involvement in it, and make sure that it is rights-based.
Thank you for shining a light on this issue and for all the work that you're doing. We appreciate you being here. Thank you. Actually, you'll take that with you. Thank you.
Now, to talk about the healthcare workforce, please welcome Her Excellency Kumbize Kandoro Chipon.